Presentations today have been fantastic. They've been so crisp and professional and really brought things together, summarised things really well. So well done to everyone that's presented this today. So what we've got now is a panel discussion around what's the role of civil society in bringing about healthy and equitable societies, and what are some of the dilemmas that involves, and can civil society compete against powerful vested interests? If you think of sort of the four bits of society that in effect organise individual life and social reproduction, there's a sort of the family and government and private sector business, and then civil society. But civil society is the one that doesn't get much airplay, isn't it? The family does, and government does, and private sector does, but civil society is frequently forgotten. Actually, forgotten's too passive. It's actually consciously and forcefully forgotten. So they're the foci of this session. As Fran mentioned earlier today, David Sanders was meant to be on this panel, but unfortunately has died. And so Fran and Toby have put together a bit of a compilation of David Sanders' thoughts. And we've got a video now, which is about 15 minutes. It's featuring David Sanders, and it's what perhaps he would have said today in response to these questions had he been able to be with us. So we'll watch the video with David, and thanks to Fran and Toby for putting it together, and then we'll bring the panel up to answer a few questions from me, and then we'll open it up for questions from, or comments as well, from you as well. So roll it, please, Frank.
Well, I was brought up in White Rhodesia. So I went to a school that was only white kids, boys and girls, and then a secondary school that was white boys only, very much modelled on a British public school where rugby was king. And of course, given my build, I only succeeded in being third reserve orange cutter for the under-13C rugby team. So I was quite oppressed at school because I was pretty weedy. So that was the beginning of my radicalization. And I was arrested a couple of times in my senior student years, during my housemanship year, basically for activism. I was only imprisoned like briefly, and I was charged and convicted of a kind of a sort of a minor offence on leading a student demonstration. But I had become radicalized, and then I got called up at the end of my housemanship year for the Rhodesian Army.
Right.
And the Rhodesian Army was already in conflict with the, at that time, nascent liberation movement.
Yeah.
Well, the liberation movement existed, but its military operations were fairly embryonic at the time, sort of starting from the late 60s. Right. So I skipped the country. And then because of activities in UK, where I went to, my political activities, I couldn't return. I could return, but I would have been very likely arrested. In my latter years in the UK, after studying in public health, I really spent the next 4 or 5 years doing mainly political work, only doing locums occasionally to earn money. And I wrote my first book, The Struggle for Health, during that period, although it was only published in the 80s, and got very involved in the Zimbabwe Solidarity Movement. And also I was one of the founders of something which still exists called the Politics of Health Group in England, with people like Leslie Doyle, who was very famous for her book, the first book on the political economy of health. So we formed the Politics for Health group. So I was very involved in political activity. Okay, so in the first book I wrote, Struggle for Health, which I'm struggling to do a new edition of, I suggested there were a number of, I suppose, areas in which the concerned health practitioner could involve him or herself. And there are a number. So one can do, for example, if one happens to be a researcher, there are areas of research, some of which you have covered very well, that desperately need to be done. So there is not enough research, in my view, on the causes of the causes, on the social determinants of various aspects. You were talking about loneliness the other day, and isolation, and the problems that young people have of feeling actually quite alone despite their social media networks.
Yeah.
So there's a lot of research that needs to be done. And there needs to be research done also on comprehensive primary health care. So where is it that primary health care has approximated the Alma Ata Declaration? What are good examples of intersectoral action for health? And actually, when I speak to people, no one can think of anything. And, well, we recently published a book which had some examples of comprehensive primary health care, but I don't feel there's nearly enough been invested. So what should young activists do? I've given a few examples, but ultimately, young activists have to become involved in social movements. Because although it's great that people do research, they teach, they provide evidence for use by the oppressed and activist groups, unless we build a social movement, a big one, which is not just confined to health services, but also interlinks with climate change movements, with movements around gender, with movements around water sanitation, and so on and so forth. Unless we build a strong movement, we're not going to actually reverse the disaster that we're.
Yeah, and David, you've been involved, you planned the first People's Health Assembly that was held in Savar in Bangladesh in 2000. What keeps you going on being involved in PHM? Why is it so important?
Okay, hi everyone. So the first People's Health Assembly was chaotic, and that's partly because I was involved in the planning.
Was everything late?
Everything was late, 10 people to a room. We had a cholera outbreak, which we managed to mop up very quickly. But apart from that, it was a very, very successful event, as you will remember.
Yes.
So what keeps me going? Well, in a way, it's what Donna said. I think, we know, and most people know, although it's not often made explicit, that health problems ultimately result from people's living and working conditions. And the gap between those who are living well and having good jobs and so on in each country and globally is widening. So even though we have all of the technologies at our disposal, we've got all of the resources we need, despite governments saying that there's austerity that needs to be imposed, we know we've got enough to actually challenge these conditions and improve people's health. So I think, you know, it's because we know that it's only right that the world's resources get more fairly distributed, and in particular, you know, resources that contribute.
David, we were asked, I mean, I think we're all reluctant to give advice to people in the UK, but are there any lessons that you'd like to just highlight before we sign off and wish everyone well for the Assembly?
Well, I think what Donna has said indicates a very important lesson. She wasn't explicit about it, but it's pretty clear, I'm sure you'd agree, because we talked about it in the last few years, that fundamentally the advances towards comprehensive primary health care here are ultimately driven by social movement. I mean, a movement of indigenous people for recognition, for self-reliance, isn't it? For sovereignty.
Yes.
And so I think that's the most important lesson for PHM, because we know that health changes happen ultimately because people organize and mobilize, make demands, and force governments and other authorities to make provision to people who, after all, pay taxes. So I think the key challenge for PHM in South Africa and elsewhere is to really develop what we call right to health campaigns, which take different forms in different countries, which start to or continue to strengthen a social movement. Where, as I think David Legg has said, we don't insist that people join PHM, although I personally think we should become a membership organization so that people feel they own it and can control it democratically. But I do think what we need to do is to identify key issues that are mobilizing or exciting people in countries around health, and as I said, they're very different in different situations, and try and build the broadest possible coalition and inject into that our political analysis. And we think that our political analysis is pretty sophisticated. Doesn't mean we can't and shouldn't learn from others.
I'm from People's Health Movement and School of Public Health, University of Western Cape, South Africa. So I just wanted to follow on Lincoln and the previous speaker. Many people invoke civil society. They say it's important to mobilize civil society in order to hold governments accountable, and of course, civil society to help raise awareness about NCDs, and certainly in South Africa, which was colored red in Thea's map. It's one of the countries in Africa where actually NCDs are completely out of control. The level of understanding of NCDs, what they are, what causes them, is extremely low. So who's going to raise consciousness and who's going to fuel activity? It can only be civil society. So civil society in this area of NCDs is extremely weak, extremely small, and in some cases conflicted in terms of getting industry funding. So where will the funds for independent civil society come from? I'd be interested, Katie might be able to answer this question. You know, public interest, NGOs, independent civil society, it's extremely important. So we've talked in the sessions about, for example, nutrition conferences that almost all of them are funded by the food industry. And we've had discussions and examples of some conferences that now refuse any food industry. So there are many ways in which civil society can take action, but always at their own expense. I've run conferences literally on no money at all, because the only money we could get chemicals from the food industry. So, I just wanted to say that. Just two more points very quickly. So, on one of the plenaries, we had someone who sang, a Japanese man. And his message was quite subtle, actually, I thought. He was talking about dying and palliative care. And I haven't seen palliative care discussed once in this conference. So, most people, including most of us in the room, especially people as old as me, will probably die of cancer, heart disease, and may require palliative care. But if you look at low and middle income countries, there's no money invested in palliative care. Most people just die suffering and pain and so on. So I think it's been a gap in the conference. And I urge the WHO, when they're thinking about this, they should also talk about this. And finally, so Fran talked about regulation of the private sector, and obviously I agree with that. And also, a big initiative to inform governments and to push governments to eliminate policy incoherence. So, for example, in South Africa, we've got this escalating epidemic of NCDs. We have government statements, but at the same time, our government is encouraging foreign direct investment from Walmart, McDonald's, Burger King, etc., etc. So governments need to be shown what the economic costs, as opposed to the benefits, which actually are usually quite small employment, not very big employment of multinationals, and we should start to push governments to invest in the small private operator. So we've done work in South Africa on the food system, and there is a very large sector of small private operators who struggle to actually provide mostly good food, vegetables, fruit, and other fresh produce, but no help from government. So we need to also be talking about taxing big corporates who are evading tax. There's a lot of evidence about that. And putting this into stimulating independent, small, private producers and giving subsidies to them. Thank you.
Thank you, David. I'd like to invite Kathy.
Fantastic illustration by David there of the importance of activism, particularly I think for any younger members of the audience today. Just the importance of what people do, you have to decide for yourself, but if you really want to change the world, then it's probably not enough just to be an academic, just work in your job, if your bureaucracy or whatever. Somehow or other you've got to get out there and get your hands dirty, and I think that's what David was brilliantly describing there from his own personal perspective. Okay, so we got almost an hour. The way we'll run it is I'm going to ask each of the four panelists, who I'm not going to introduce because they've all spoken earlier today, so you know who they are. I'm going to ask each of them a question, and then we'll see how we're going time-wise with other questions, and then I'm hoping to bring in yourselves. And I will take comments, not just questions, but keep them brief, okay? All right, so first questions for Ross. So, can you describe the campaign that SECOS ran in the 2014 South Australian election that promoted the value of taxation to community services? I know this is something you feel strongly about, and why we should all be concerned about tax as an issue in the context of what we've been talking about today.
So I'm going to swap spots.
Yep.
No,
Yeah,
I need... Now, hopefully I can make the magic work. And if I can't make the magic work, then Frank's going to help. So the question is why? And the answer is actually relatively simple. It's that unless our governments have a revenue base that they can use to fund the kinds of services that we want and need, then we're in trouble. And we can argue all we like about the way our governments spend money, but fundamentally they still need money to be able to deliver the things that we want. And when you look across the world, what you see is that the places that have some of the more advanced social conditions and social arrangements appear to be places where there's a comfort with spending and giving taxes across to the government. It's an expectation. But in fact, in our country, I think we have our favourite thing is to want to say, well, it's up to everybody else. And in the lead up to the 2014 election, we were in a position where there's no one saying revenue is important. But we were wanting to ask things of the government. And they were saying, well, there's no money. How are you going to make it happen? And we say, well, let's get some more money. Let's actually make it happen. Now, it started with an idea, and I'll just show you this. This is our version of how we began our little campaign. We had no money. And so we, if I'm very clever,
it might surprise you to know that Australia is one of the lowest taxing countries in the developed world. Per head of population, South Australians pay less in state taxes than the national average, and about $90 a year less in real terms last year than we did 5 years ago. And while no one really likes paying taxes, they're needed to pay for vital services the community needs, like schools, hospitals, roads, police, and support for vulnerable members of our community. Don't be fooled by cheap tax cuts. Without taxes, vital services disappear. Spoken by Luke Penman, authorised by Ross Wormersley for the South Australian Council of Social Service.
Now, of course, elections are the times where our governments come to power and they promise tax cuts. Doesn't matter what persuasion they appear to be, that's what they do. And it's this incredible fight to the bottom. And so we tried to get this campaign launched 6 months out before the election, had very little resources, and as you can see from that, that's our best in-house efforts, trying to make something work. And we did a whole range of things. We kind of created, we did go to our members and say, look, we want to run this campaign, we need your support. There were various reactions from our members, most of whom are charities, and so see firsthand the outcomes of what happens when governments cut services. Because governments almost always cut themselves last. And so funding that might be coming out to non-government organisations is often first in line to be cut, but at the same time as they reduce services, where do people turn up? It's at the lineups for help from many of the charitable organisations. So there were a few of them that gave us some money. We didn't get a lot, but we got a little bit, more than 50 grand, I think, in the end. So that was a pretty good effort, we thought. And we created things, like we created that, and we created a little postcard that we could give, and we distributed those postcards to all of the key marginal electorates. So we chose 5, including the leaders' electorates, and made sure that they were being postboxed, and we produced other paraphernalia as well. Just trying to get the message across. We also talked to the government about and the opposition about the fact that we were going to put on public display what they were doing. And so the Wednesday before the election, we actually published a report card that said, this is how we rate your performance, both on an overarching kind of tax policy, revenue policy set of arrangements, but also on the other range of issues that SACOS, takes a very keen interest in. And that's become very important political collateral. Because in fact, shaming and naming is one of the things that we can hold against the political interests. Now, we could only afford to buy ourselves half a page in the Tiser, and people were, pretty excited. But we didn't need more than that to make a bit of a fuss and make enough noise. But we also did one other thing, and that was we actually had a little bit of money, and we decided to try and talk to our friends at 5AA about, if we want to talk to people about this idea, how do we get the people on side? Because we talked earlier today, we talked a lot about the policy stuff, and we talk about that all of the time. But in fact, and our version of what we needed to say to people was that earlier ad that I ran for you. But in fact, when we talked to AA, they gave us a different version.
A world without taxes sounds pretty good. You've got more money to spend on yourself. But imagine you're sitting on the sofa, you hear a siren, your neighbour's house is on fire. There's no fire department. Well, sure, you can put it out better than any professional firefighter. Go on, grab your hose. Without taxes, the vital services we all take for granted will simply disappear. South Australia needs a fairer tax system, one that raises enough money to meet community needs. A message from SACOS.
So we had about 20 grand. The interesting thing about that is we ran that. It also led to a whole lot of influence. So when I was talking to Leon, and I talked to Leon quite a lot, but taxes in Leon is not a conversation he likes to have. He doesn't actually want to be friends with people that are promoting the idea of paying more tax. And but the interesting thing is, through the lead up to the election, the very fact that we were advertising with the station led to a whole lot of positive editorial interaction. So I actually got some slots with Leon where I actually got to talk our side of this story. So in fact, very interesting, was very cheap really, but very interesting way of trying to shape. And of course, just a message for all of us about how important it is to know who the audience is that we're talking to. And of course, if we want public support for these kinds of things, we may need to find different ways to talking to people about the things that count for them.
Yeah, I mean, great example of, I can't remember who this morning raised the issue of framing, but about how you frame an issue like paying more tax. And there is somebody who wants to pay more tax.
Good on you.
Sorry? Yeah, no, not in South Australia. No. A lot of bloody lefty pot smokers. Tessa, you next. So how can we engage non-health civil society and leadership from civil society? And how can we marshal different voices for health equity? So how do we get everyone else involved in the health and health equity debate? You got the mic. Good.
Thanks, Peter. And I think I would start by saying I think that's the next opportunity. It's a challenge, but it's also the next stage in terms of, how we think about translating the lessons of, the past 4 years of the CRE and the many other actors who are looking at those barriers to embedding this knowledge in our policy and our practice. So the way we're thinking about that at Health Justice Australia is through our work with Health and Human Services. So Health Justice Australia is a national charity and a centre of excellence supporting creating health justice partnerships. And these are essentially collaborations between service organisations that embed legal help into healthcare teams and settings, with the idea that lawyers can be good for your health. And the way that they can be good for your health is by tackling the underlying drivers, the underlying causes that are making you sick. So this is mostly community legal services, and the kinds of problems in people's lives that lawyers can help with are, the inadequacy of housing. That means particularly public or rental housing, high levels of mould. The health system's become very good at recognising the mould is the driver of respiratory problems or spread of infection, but it doesn't necessarily have the levers to get that housing fixed. So when you bring legal help into a healthcare team, now we've got the mechanism to threaten legal action if hygienic housing isn't provided. And we have no intention of taking legal action. We want to get the housing fixed. So already in that example, you can see that idea about a social model of health, an understanding of the social problems in people's lives that are driving their illness, from that kind of stuff of life to credit and debt, accumulated fines on the private toll roads that many people are now needing to travel to get to work, right through to huge, phenomenal amounts of family violence being identified through these collaborations, and then enabling different kinds of service level responses. So in these collaborations, the language of social determinants of health is alive and well. And often practitioners say to us, often legal practitioners say to us, we're fixing the social determinants of health in our health justice partnerships. And what they mean is they've fixed the housing that was making someone sick, or they've given a woman the information she needed to separate her superannuation out from her partner's so that she could have some space to think about what else she might do in the context of the violence that she was living with. So I know in this room and from my years now of working with Sharon and Fran that they're not fixing the social determinant that is housing. They're not fixing the availability and the adequacy of housing stock. But if we want them to be part of the movement around the social determinants of health, we need to find a way to translate our understanding about the social determinants of health into really practical and really tangible understanding for a whole lot of people who are never going to be across the detail, who are never going to necessarily read through and understand and synthesise that detail, but who can be really active allies and really active partners in this movement. So that's my first answer to the question about how do we mobilise other voices and mobilise that movement. And it's about recognising that translation is not actually the same as dissemination. Translation isn't just distilling your key findings into a pithy narrative for a new audience. I think translation involves much more give and take. And so our ability to work with legal practitioners, particularly in this context, to help them see the strength of what they're doing, to help them mobilise the frame around social determinants, to think about what they might do, for instance, around systemic advocacy, as well as around individual level of service delivery, I think that's on us, not only on them. And so that's why I'm always interested in that translation piece, because if we want to mobilise stronger civil society voices around this work, we need to be able to connect with the issues and what resonates with those actors in civil society. So that's the sort of example that I think is both relevant in terms of the discussion today and also highly translatable. In my work, and Ross and I were talking about this morning, in my work there is increasing recognition around complexity. There is increasing recognition that many people, particularly people experiencing socioeconomic disadvantage, people who are vulnerable to unmet needs, people who are experiencing poor health, that many people in those situations have multiple intersecting problems going on in their lives. There is increasing recognition from governments that the nature of that complexity is a key priority for them. But there's also increasing recognition that they don't have all the answers, that government alone cannot reshape entrenched systems around the needs of the communities that those systems are here to serve. So that's the other opportunity for civil society to be part of the leadership around what that can look like. And so the second way I think we can really drive that path and enable that conversation is to look at the very many and evolving models of communities in control. And the Aboriginal community controlled sector in Australia, whether it's in health or legal or childcare or other contexts, has been leading this work for decades. The emergence of collective impact, another way of helping communities think about, identify and respond to the problems and their own priorities in their work. The emergence of peer workforce models, particularly in mental health, around organising for sex workers. I mean, these are many, many examples of what it looks like to have communities at the heart and the head of addressing their own problems. And that, I think, is really critical from the evidence about social determinants of health, but it's also a really critical mechanism for mobilising civil society. And then the third one, and I'll finish on this, is I suppose, having thought about Sharon and Fran's reflection that, the conversations at the WHO about the social determinants of health couldn't really move past what does it look like for the healthcare sector to change and to respond to this agenda. And I really understand that frustration, and most of my work has been about mobilising non-health actors on these issues. But increasingly in the work that we're doing, we are hearing from practitioners who say, from health practitioners, from actors in the healthcare system who say, now that I understand the social determinants of health, what can I do about them? And that is from your street level GP to your allied health professional working in regional or remote communities. And so they can be really powerful actors in what they do. And we have to find a way of bringing them along in this discussion that doesn't say, well, really the only thing you can do is get your professional body, get the AMA or the RACGP to, advocate for a social model of health. We have to find a way for them to make sense of the knowledge and the understanding about the social drivers in health in a way that gives them some agency and brings them along in the process. And so, again, in the work that we're doing, the knowledge about what are the many non-medical problems in people's lives that make them sick is something that people can respond to and can relate to very quickly. But then the different ways that you can enable people to engage in a structural analysis and a structural driver around that, well, we have to find really creative ways and really meaningful ways to really lay out that path for people.
Just before you pass that microphone on, go just really quickly, because we do need to keep moving. So, who kick-started Health Justice Australia? How did it get going? Was that just somebody with a bright idea, or did it come from health? Did it come from lawyers? What was the beginning of the idea?
So in Australia, this work has been led very much by community sector lawyers, and Health Justice Australia as a charity and as a centre of excellence emerged from the practice. So these partnerships had been coming online since 2013. By 2015, there was a sense that there was a movement across health and legal practitioners, and they wanted a national body to drive their effectiveness. What's interesting about that is it's an import of a model that's been running in the US for 20 years, and in the US it was emergency department doctors, but for exactly the same reason, that emergency department doctors in Boston recognised that they could do nothing about preventable hospital admissions until they addressed the housing that a particular community was residing in. And that, for me, is the point that says these principles are working in this particular space, but they're highly translatable. The idea that we identify at a local level and at a tangible level how these factors are playing out, and then we support people to respond differently, that's the mechanism for systems change.
Okay, good. But lawyers get a bad rap, don't they? But I'm peripherally involved with 2 lawyers groups in New South Wales who, just so committed to good social change. Phenomenal. Okay, Belle, you're next on. Thanks a lot, Tessa. So, what lessons have emerged from studying agenda setting for health in areas outside our own policy domain, so in areas like employment and macroeconomics and trade and welfare? What are the lessons you've learned and synthesised from your work?
So it's been really interesting looking at 3 distinct policy domains. So employment through the paid parental leave case study, macroeconomics and trade through the Trans-Pacific Partnership case study, and then you could call welfare, but really is a policy about how racism embeds itself through the Northern Territory intervention. And what's been really interesting through understanding retrospectively the agenda setting processes in these case studies is the similarities and differences around the barriers, but also the enabling factors that either, enable or constrain getting attention to health and to health equity on these distinct agendas. So I think three, I guess, broad factors of constraints that we identified across these very distinct case studies, if you think about ideas, and we've talked about the role of framing, and I think this, the dominant neoliberal discourse around, markets being the most effective mechanism to advance society, and the assumptions within that about, economic growth will trickle down for everyone, and therefore the role of the state should be to facilitate the markets, is something that's a barrier that we've identified in all of our case studies, not just agenda setting. But then you also have pervasive racist ideologies that were through the intervention, but also were evident in the other case studies when we asked policymakers, well, did you consider or consult with Aboriginal and Torres Strait Islander groups in these policies? For example, in trade policy, where there are discussions around traditional knowledge, and the answer was just, no, we didn't do that. And then thirdly, sort of social conservative ideologies that are also prevalent within Australian discourse. They were prevalent in the paid parental leave case study, but also in the intervention case study, when the Howard government used sort of really social conservative views about children and protecting children behind quite a racist discourse about Aboriginal people. And then, as Sharon mentioned earlier, we find that in the policy processes we come up against these barriers when we're trying to operate outside of what people see to be the health domain, and sometimes we encounter closed doors or clear differences in whether there are consultations with industry versus the level of consultation with public health. And then those broader power asymmetries in the forums and the venues. For example, in the paid parental leave case study, the industrial relations venue is being quite constraining for health. And so we have those ideational, structural and institutional processes that create these barriers. But from the case studies, we can see little glimmers of hope of how to navigate them. And I think if I was to rank them, I would say the paid parental leave case is sort of perhaps the most telling for how health did get on the agenda. We saw in the trade study, as Ashley mentioned earlier, some attention to health, in particular around issues of tobacco and medicines, and then in the intervention, quite a racist policy, but as Tamara mentioned, ongoing resistance and some small defeats. So that's how I'd sort of rank them. And through them we see, I guess, three key things that worked. One is the issue of strategic framing. So do we go into a policy department and just go health for all, health equity, or do we need to be more nuanced in identifying the frames and objectives that policymakers use that aren't necessarily health, but they align with what we want? So in the paid parental leave study, identifying if we make this about gender equality as well as health, as well as economics, we can bring these people together and we can push these visions together. And in the trade study, we saw the success of access to medicines was because you could align arguments for access to medicines with a particular economic way of thinking, and so you could navigate equity and economics together. And then that point about broad coalitions, again in the paid parental leave study, it required health actors working with trade unions, working with women's organisations, working with public servants, and then bringing in industry actors that were supportive. In the trade study, we saw one of the reasons why there was such attention to access to medicines was because some industry actors also supported the case for access to medicines, and the Productivity Commission released a report, an economic case for access to medicine. So thinking not just, most of us in the room I think are public health, but who are our allies, as Tessa mentioned, that we wouldn't normally work with, but who are actually on the same page, but we don't normally think of them. And then thirdly, that idea of forum shopping or venue shopping. So do we stick at the argument within a venue if it's just not going anywhere and we're encountering these power asymmetries? Can we strategically work to move to another venue where we can kind of break open that discourse and bring other framings in? And I think those are the three lessons, or the lessons of hope from these case studies about what do you do when you're coming up against quite a lot of barriers when you're outside what people see as the health space and you shouldn't be there. And yeah.
Strategic framing, broad coalitions, and forum shopping. Thank you very much. Okay. Fran, how do you think the People's Health Movement could become more successful as a voice for the social determinants of health?
Yeah, thanks, Peter.
Either in Australia or globally?
Yeah, well, globally, I mean, I think we have been a voice, obviously, and you are saying more. And if people want to read the People's Charter for Health that came out of the first People's Health Assembly in 2000, you'll see how much that's laid out. It's actually been translated into as many languages as the Bible now. So it has been spread very wide. And have a look on the website of the PHM, you can find that. I remember when I was on the Commission on the Social Determinants of Health, one of the other commissioners was a woman called Monique Béjean, who had been the health minister in Canada, the federal health minister under Pierre Trudeau. And Monique and I became very good friends. And one day she said to me, you know, she comes from Quebec. She said, you know, the People's Health Movement. Why aren't you having people in it? And what she meant by that was that as she met my comrades in the People's Health Movement, we were all researchers or doctors or nurses, and they weren't the people. And she was right in a way. So for me, that's the question, you know, how do you get a popular constituency so that they do stand up? And as Sharon said, it looks like we're going to have a preventive health strategy that's based on behavioural strategies. Now, how can we have a citizen's voice that says, don't tell us how to behave, you know, make healthy choices the easy choices. And that for me is the challenge. And I'm not entirely sure how you do it. I mean, one of the best techniques, I don't know if you remember the slide when we saw David's, there was a group of, I think I was in it, and Zafrullah Chowdhury, if people know him from Zimbabwe, were there. But a number of the people in that were the founding members of the People's Health Council that had as its guiding slogan, the struggle for health is a struggle for liberation, because they all came from countries like Zimbabwe, Nicaragua, Palestine, the Philippines, who were struggling for national liberation. And a lot of those people would use techniques like Paulo Freire's popular education, where you would start with their particular issue, but you would keep asking them why. So, for instance, if you took the issue that Tessa raised of speeding fines, you'd say, okay, you're in debt. Why? Oh, I've got a speeding fine. Why have you got a speeding fine? Because I have to go to work in a car. Why do you have to go to work in a car? There's not good public transport in Sydney. Why isn't there good public transport in Sydney? The government haven't invested in it. Why haven't they invested in it? Well, they have a policy of privatisation, and they get, you know, and you can see how by keep asking why, you very quickly get to the root cause of a problem. And I think in the 1980s, as part of the community health movement in Adelaide, we had an adapted version of that. I'm looking at Carmel because a number of us were involved. And we used to do that in the No Longer Healthy Cities program. We'd sit down and unpack problems using that popular education technique. But I think you need, you know, it's not something you can just go off and do as individuals. You need a community health centre, or you need a mechanism by which that happens. But I think that's the kind of thing we need to do. And it's a consciousness raising process. You know, it is saying that you will not be healthy if you get another hospital. You're much more likely to be healthy if we give everybody a house. So, you know, I'm not quite sure how we do that. But I should give a plug for Friday. The People's Health Movement will be meeting on the other side of Victoria Square, and from 9 o'clock till 4:30, with of course an hour and a half break at lunchtime to go to the climate change march. But you will there get a chance to hear more about the work of the People's Health Movement, and we're putting a big focus on welfare reform, particularly New Start, and I think, and having people from a very successful, I guess it is a citizens movement, the Anti-Poverty Network in South Australia, which really has fought for the rights of welfare recipients, entirely organised by people who are living on welfare. And really, last week, they all went to Canberra with the Unemployed Workers Union, and there they were walking the corridors of power, literally talking directly to politicians. So that, for me, is another movement, and on Friday we'll be hearing from them as a kind of a model and a way that PHM can link with other groups.
So I'm going to throw it open to you folks now. We'll try and keep it moving in what I think is probably only about 10 minutes left. So put your hand up, and we need to take one of the mics. Kat, Sue, thank you. Who'd like to ask the first question or make the first point? Or tell one of these four they've been talking a crock of proverbial? Okay.
Thanks. John Connor from Flinders. The thing that's really stuck in my mind, Fran, is one of the first things you said this morning was that improving health equity isn't good for just those who are going to improve, it's good for society as a whole. I was just wondering if you could talk a little bit more about that in terms of how convincing is that evidence? Could it be more convincing? And is that a real lever to act?
Yeah, I think people find that hard to grasp, but obviously it's based on Richard Wilkinson's work on the spirit level that shows that countries that have high levels of inequity also score badly on a whole range of health and social well-being factors. So, in other words, equity is good for the whole population and is good for health. And the way I usually say that to people is if you think of really unequal countries like Brazil and South Africa, you can just see the quality of life where people have to put up big barriers, surround themselves with, if you've been to South Africa, which has one of the highest, worst Gini coefficients, which is a way of measuring inequity in the world, you just can see it in the way people live. There just isn't a kind of a solidarity. And then by contrast, if you go to a Scandinavian country, you can see it is safer, that people generally are getting on better and so on. So I think people do get it then. And one of the big concerns of most populations is safety. We all want to be safe. And more equal countries are much safer. They have lower gun violence, they have lower murder rates as well. So I think it's sort of getting those messages over, really. But how do you do it? Well, I mean, I think you can put out the evidence there, and I think you can tell stories about that. Say, have you been to South Africa? Have you been to those countries that and try and put that over? Yeah, I mean, at the moment, Australia is, I think, moving towards more. We're going to. I mean, I actually predict that we'll start seeing in some social classes declining life expectancy in Australia in the next 10 years, anyway, and that really would be a wake-up call. But those data on health inequities at the moment, life expectancy is going up, but with that increasing inequity, I think we could see declining life expectancies, which probably would wake people up, because then they'd say why. But it is very hard because people are saying, it does get into this whole debate about what do we measure, and what we measure at the moment is GDP. And of course, we've had lots of discussions worldwide now about alternative measures of well-being, whether it's the we've done some work on the Genuine Progress Indicator, but there's the New Economics Foundation in England, that's looking at all sorts of indicators that are alternative to the GDP. And the research we're doing around countries that have really good health, despite having relatively low GDPs, and asking why do they do that? One of the answers seemed to be they have a civil war, isn't it? Or they have some big conflict, and that seems to lead to good health. I mean, but it's not the only one, but there's also good public policies that invest in that. So I suppose, I don't know, I mean, it's a hard one to say. How do you get those messages out there? But I think it's an important one to try and do.
Okay. I'm sorry, I've forgotten your name. Jan. Now, before you go, I'm going to ask one of you to go for 30 seconds on one thing. Okay, Tessa, I'm going to start with you. So.
I thought he meant to.
No.
Like, okay,
I'm
ready.
going to come to that in a moment. So, they've had warning, so they should. I want you to give me one opportunity for mobilising civil society around the social determinants of health in Australia. In 30 seconds, what's one thing we could do to mobilise civil society around the social determinants of health? Go.
Support the Uluru Statement from the Heart, voice treaty truth.
Great.
We need, it's not on Aboriginal people's backs alone, it's not on First Nations alone to see that massive ongoing legacy of injustice addressed. That would be the one thing.
Super choice, Jan.
Oh, okay. Did you want me to respond to this?
No.
Oh,
You can ask your question.
Just checking. My question would be for David Sanders, so I'll open it up to anyone, but I'm very cynical, but I am filled with hope sometimes about the outrage that my generation, but especially my sister's generation, is demonstrating around climate change, etc. However, it sort of hammered home the point in a lecture on Monday I was at, where the woman sort of coming up and saying, well, the student saying, okay, everyone, you should come to this. And by the way, the University of Melbourne has said that if you skip an exam or a tutorial or something, you will not be penalized. And it kind of reminded me that there are huge, significant consequences for that outrage, whether it's from our employer, whether you're a student. So I guess I was just curious, do you see any ways that we can more effectively enable people to practice that outrage without devastating consequences for our careers, etc.?
One person, because I want to keep things moving. Who'd like to have a go at that? Bill? Okay.
I was going to say join the union. No, students can join the National Tertiary Education Union. I'm a delegate. No, so your question was how can we ensure that we take action where we're not going to suffer adversely from our employers? Yeah.
Sorry, what was that?
Oh, can we just make it, can we be more protected so that more people are willing to do it?
Can we be more protected so that people are willing to do it? I'm going to make a comment on that afterwards.
Yeah, well, I think that's why it is important that we all turn up to the climate strike on Friday. I know there was some discussion earlier about are we taking over from young people, but I think having one of the reasons that our National Tertiary Education Union has called for all universities to support staff and students going is because we don't want people to be adversely affected or penalised, and we want to have solidarity together. And I think the only way to stop being picked off one by one is to have solidarity in a large group. And so whether that's through the union or whether that's through broad civil society movement of people coming out and saying if you adversely, if you negatively punish someone for taking this action for a health equity purpose, we won't stand for it. So that kind of broad solidarity is the only way to avoid being picked off.
Can I just ask, I mean, outrage, but you're being supported by your employer? Just seems a bit peculiar, this, to me, doesn't it? I mean, isn't this just capture of the outrage by the capitalist hegemony? I mean, it just seems odd to me. If you're going to demonstrate, you're on strike, but your employer approves it. Come on, this is, But anyway, I just think it's a bit odd, all this. But anyway, Ross, did you want to say something as well?
Just to clarify, I'm happy for people to go along and support the kids. Just don't take their place and don't take over from them.
Okay, thanks, Kat. Fran, the one question, what's one opportunity for mobilising civil society around the social determinants of health in Australia?
Well, I mean, I do think it's an alliance with the climate change movement generally, because if we don't do that, we're not going to have we'll have a planet, but it won't be a planet fit for humans. So the social determinants will be neither here nor there if we stuff up the ecological determinants. So of course they go hand in hand, but to me that's the most vital thing we need to do.
Two great answers so far. Thank you. And then Dr. Harris after that.
Hey. I just thought I'd mention that the Friday protests are coming out of the weekly student protests on Fridays, in which they've said, can, adults and businesses and everybody else come together in supporting us? So I guess I'm interested in the framing of we don't want to speak for the kids, and I guess the same with the Uluru statement when people are saying, as was mentioned on the panel, it's not up to young people and people in positions of vulnerability alone. So can we mobilise to support people when they ask for it without doing that?
Was that a statement, or do you want answers to that?
Well, I feel like you guys are kind of saying, is this going to be useful or striking in this way? But if it's something that's being requested by these people, are you suggesting that there's other things that we should be doing?
I think Ross is suggesting it not be taken over by the others.
So what would it look like for us to mobilise to support without taking over in a way that can lead to kind of power shifting, but actually changing systems at the same time, if you know what I mean?
Yeah, I mean, remember that in the charitable sector, many organisations have made enormous point of saving and rescuing and taking over and looking after people. And in fact, while Fram's absolutely right, climate change has to be one of the front and centre issues that we ought to all be worried about and taking up. And if you're someone who is poor or disadvantaged, then in fact you're going to be on the worst end of it. So there's absolutely not a shadow of a doubt in my mind about its importance. But I'm always a little concerned about when we start to take over other people's agenda. And I do think it's really important, though, to show solidarity and to be there in support of. And in fact, on behalf, we need to stand shoulder to shoulder, not just with the kids, but we need to stand shoulder to shoulder with our brothers and sisters and cousins who happen to be Aboriginal or from the Torres Strait Islands in this country. We have to stand shoulder to shoulder with people who are having a really, really hard time in this country, because that's our job. If we want a good community, if we want a more equal community, we need to be prepared to step out, and we can't allow the silence to sit there. So one of the problems that I think that has inhabited our political and our media space is that in the we're anxious about jumping into it because we're not sure that we've got a real solution to it, or we're going to get picked on and someone's going to give us a hard time. But if we don't step into that conversation, if we don't front the media and say, no, this is unacceptable, if we don't say we need to have more taxation revenue, or if we don't say we need to address climate change, or we need to address poverty, then in fact we're failing ourselves and we're failing our community. And we're certainly not going to be doing our job as good citizens. So I think we absolutely need to fill those silences, because in the absence of the silence, what voices do you hear? All of the crap, all of the nastiness, all of the racist stuff, all of the stuff that is about self-interest and greed. And it's absolutely imperative that we all, as individual citizens and as collectives, actually make the decision to stand up for stuff and not to be silent about the things that are problematic.
Okay, Belle, it's your turn. What's one opportunity for mobilising civil society to effect... Sorry, wrong question. What's the opportunity for mobilising civil society around the social determinants of health in Australia? One opportunity.
Oh, I don't want to throw another one in. I mean, I guess I still feel like the global climate strike is the... and
okay.
Yeah, and the rallying around New Start are the two things that are kind of on the agenda at the moment. And... going out and supporting the climate strike and supporting the Raise the New Start seem to be the two agendas that are getting the most traction. So I guess strategically is it that we all sort of promote these as their hot issues and do what we can from our little perspectives, rather than try and throw out, I don't want to throw out another one and be like this one as well as the Uluru statement.
Yeah, no, that's good. Go with something that's hot. We've got about 4 minutes left. We've got till 4:56, I think, according to my running sheet. So, Patrick.
A very sort of quick question to everybody, I guess, or someone who's really interested in it. I was a bit shocked about Sharon's and your, Fran, point about the WHO Determinants of Health Office not being able to get around health services. And it made me think, what do we do about the looming spectre of medicalisation of everything?
Yeah, no, I think Sharon said that some of the people at the meeting, I mean, I only zoomed in.
So it's the same question, and sorry to come across you, but then it's how do you build coalitions when you've got a very powerful medicalisation of a public health voice?
Yeah, and I think we've had discussions that
that we're in a period in which there is a kind of remedicalisation, particularly in the face of burgeoning medical technology, and some of it genetic, but also particularly, well, worldwide, an increased focus on privatisation of health services so capital can see that they make a buck. And I think it's very difficult. I think we just have to keep standing up and arguing for the value of the public sector, and particularly the value of the public sector in a whole lot of services that are social determinants of health, like water, energy, transport, health, and so on. That's what I'd say. But yeah, I think there is a real issue of the medicalisation.
Tessa, do you want to say something?
Yeah, I mean, I've been looking at what is clearly a race across universities around precision medicine, around who is doing the most technological innovation. I mean, we are so not interested in what community level innovation looks like. We don't even have a language for it, but precision medicine, that's where it's at. And I really struggle in those conversations that are showcasing innovation and research. Where is the conversation about values? Where is the conversation about equity? I mean, these are far more your colleagues than mine in one sense. So I think there's a shared project around not to check research and not to check the pursuit of knowledge, but to make sure that it is always framed around values and equity.
Okay, Ross, it's your turn. One opportunity for mobilising civil society around social determinants of health at the moment?
Look, I'm categorical. It's our support to our Aboriginal brothers and sisters. We actually have to stand in enormous solidarity. They have endured, they have been overtaken. This is land that has belonged to them. And if we got that relationship right, we would learn an awful lot about getting the relationship with everybody else right as well.
Good, thanks.
It seems to me that there's a huge gap between people's personal experiences of NCDs, which you see in the media frequently, and people's willingness to, engage with ideas about redistribution, taxation, addressing health equity. So, and the average person isn't aware of, what is a social determinant of health, what is a commercial determinant of health. So it seems to me if you're going to engage constituents, there needs to be, bridging the gap between those personal experience of NCDs and social determinants and, solutions for those.
Does anyone want to make a comment?
I mean, I guess we need to go back to 5AA, our commercial radio stations, and ask them how to bridge that gap. We need to find the way, the language that we need to use, and it's probably not going to be our language.
I mean, as you know, Sam, the other thing is that there's a whole lot of framing of NCDs by corporations that are deliberately designed to make it individualised and about people's individual food choices and particularly exercise choices. So for me, it's structural solutions like controlling advertising and, doing a whole lot of things that stress that NCDs are about those broader factors, because they're very powerful voices. It's not like it's a neutral environment. There's very powerful voices that are constantly in the media, constantly in the ears of politicians, pushing exactly that individualised messages around a whole range of diseases.
Okay, I'm going to draw it to a close there with a couple of recommendations from me. If you want to understand how it came about that neoliberalism was a joke in the 50s and since the 80s has dominated economics, then I thoroughly recommend Nancy MacLean's book, Democracy in Chains. If you haven't read it, it's an easy read, relatively easy read. It just describes how that has come about politically. And that agenda has by no means run its course. They've got grander aims still. And if you want to understand it from an economics perspective and a progressive economics agenda, then have a look at Kate Rawson's book, Don't Economics. I thoroughly recommend both of those books in terms of understanding a lot of where we're at these days. Can I ask you to join me in thanking Fran, Tessa, Ross and Belle for a great panel discussion. Thank you. And now you're going to wrap up. And Fran Bound's going to make some closing comments.
Yeah, and I'm going to be very brief. Firstly, to thank Peter again for chairing our critical reference group and also for chairing this session. Thank you very much. That was really good. This will be the last big event that the CRE runs, very sadly. So I do want to thank all those members of our Critical Policy Reference Group. I'd like to very much thank Sharon. It's been great fun. We conceived of this CRE one afternoon at my house with butcher's paper. No, 2 days we spent, didn't we, battling it out. And it's great that it actually got funded, and it's great that we've got through. We've still got a bit of writing to do, but we're sort of through some of it. And I'd, of course, like to thank our fantastic research team. You've seen them in action, so thanks to them. They're brilliant. I'd also like to thank our fantastic admin team, Kat and Sue, who are both at the back. They've done a brilliant job. I'd like to thank Frank Meany, who's made everything go smoothly. Frank, I think I've been at conferences with Frank for like 32 years or something, so it's a long time. And sign up to our mailing list, let Kat or Sue know. Watch both the RegNet website and the Southgate website, because we do have a lot of policy translation events on there, so please keep an eye on those. And I'd also like to thank the NH and MRC, because they funded us, and whatever we say about if there's a medical bias in the NH and MRC, I think in funding our CRE, they really were funding the H in their name, the health bit, not just the medical bit. So many thanks to NH and MRC. We will be now, our concentration for sort of the final months of the CRE, we have these very strict writing plans that we all have to stick to. We had a writing retreat in August, and we've made these overly ambitious plans that are going to make us all feel guilty for the rest of the next 6 months or so. But that will be happening, and those plans include writing policy briefs that we will aim at policymakers, so it's not just the academic stuff. And I would like to say again, there's leaflets outside, but on Friday we do have this very good workshop looking at neoliberalism, economy and ecology, and it will be a very exciting one. And it involves the political economy of health group of the Public Health Association, the International Health Group, and the People's Health Movement in Australia. So that will be a great day. So that's it, folks, as I say. And the final thank you is to all of you for coming. You've been a great audience, and it's great to see so many of you. And I've got one more. Melissa Sweet has been our amazing anchor of our... Now, pardon? Oh yes, we're apparently the hashtag CRE Health Equity has been trending since about 11 o'clock this morning, and I keep getting emails telling me it's trending. So I think that's thanks to Melissa, who sort of is gathering us all up. And if you haven't followed Melissa's tweets, just go into Twitter and hashtag CRE Health Equity, and there's all the tweets that people have put that on today, and you can sort of follow the whole day really in the discussion. So that's a real plug to go onto Twitter, because it's a really good thing. And for the rest of the week, members of the CRE Health Equity will be also tweeting under the We Public Health handle. So you will sort of see us popping up there too. So good use of social media. So thank you very much, everybody. Thanks for coming. And we have got drinks and a chance for some lovely networking outside. Thank you.